Mantle cell lymphoma is one of the less common lymphomas. It accounts for about 5 to 10% of people with lymphoma. It is more common in older men for some reason. The median or more or less average age is around 65, and there's about a 2 to 3 to 1 male to female predominance. So mantle cell typically presents itself like many other lymphomas, with a swollen lymph node somewhere, a mass, a lump. It also can sometimes present with symptoms. Sometimes it's in the blood, so a blood test demonstrates abnormal white blood cells in the blood. Sometimes patients can have an enlarged spleen, so they may have abdominal symptoms. Spleen is a fancy lymph node in the abdomen. And sometimes patients can have anemia, low blood counts, low platelets, which are the cells that prevent bleeding. So it's a number of different ways that patients present. I would say most commonly it's a lump somewhere that leads to the diagnosis. So typically mantle cell lymphoma is diagnosed with a biopsy. It's most commonly a lymph node biopsy. Sometimes the diagnosis can be made on a bone marrow biopsy or a blood evaluation if it's in the blood. Occasionally patients are diagnosed with involvement of the gastrointestinal tract. So there are some patients who get a routine screening colonoscopy, a polyp is noted, that's biopsied, and it turns out to be a lymphoma. So that occasionally happens, but most commonly it's a lymph node biopsy. Diagnostic tests are very important in every lymphoma. There are over 80 types of lymphoma. One needs to know what type one's dealing with. Mantle cell lymphoma has a typical appearance under the microscope. It has a certain what we call immunophenotype, meaning the proteins on the surface of the cell are characteristic of mantle cell lymphoma, so the pathologists make the diagnosis with looking at what are called those markers. Mantle cell also has a characteristic cytogenetic or genetic change where chromosome 11 and chromosome 14 are misaligned or mishooked up to each other, and that's something that is typical of mantle cell lymphoma and has something to do with why the cells are growing. So those tests are useful in diagnosing mantle cell lymphoma. The tests that we look at to predict relapse are a little more controversial as to how good they are. There's a marker called Ki-67, which is a marker that tells you in the lymph node what percentages of the cells are in the middle of growing, of dividing at a given time. And if that amount is high, that tends to be less favorable, but that remains a little bit of a debatable thing. There's also a lot of research going on now in what's called minimal residual disease, really molecular ways of saying the patient's in remission, they've had their treatment, the scans all look fine. Is there molecular evidence of disease in the blood, in the bone marrow that we can detect? And that may, it seems, correlate with a better or worse outcome if you can detect that. But that is really something that is a research tool primarily at this point. And a lot of our clinical trials are now focusing on, can we get patients to a minimal residual disease state? Is there value to that? Should we change therapy on that basis, give additional or less therapy based on whether or not they are what are termed MRD positive, meaning that you see this? And I think the jury is still out. It's not something that we typically use in clinical practice, but I think will be a tool that in the future might be helpful in guiding therapy. Mantle cell lymphoma is among the most challenging, in fact some people call it the most challenging lymphoma, or MCL, because it's really, there are many different treatment options. Historically, mantle cell patients have been treated with chemotherapy, and generally speaking, younger, more fit patients were treated with more intensive chemotherapy. Older, more frail patients were treated with less intensive chemotherapy. But the situation with mantle cell has evolved over the last 5 to 10 years, and there are lots of different approaches, and the pros and cons of different approaches, I think, are actively being debated and discussed and studied in clinical trials. We've learned that, like other indolent lymphomas, the other types of lymphoma that are the indolent histologies, mantle cell lymphoma in some cases doesn't need treatment right away. Some patients can be observed, as in the other indolent lymphomas, if they have no symptoms. We have a number of different chemotherapy regimens that we use. And the other issue that has often come up in mantle cell lymphoma is, should the patient get an intensive treatment, such as autologous stem cell transplant, as part of their initial therapy. In general, the more intensive treatments are more effective at keeping the disease in remission longer, but have more side effects, generally require inpatient treatment for at least part of the treatment. The less intensive treatments have fewer side effects, but perhaps don't keep the disease quiet or in remission quite as long. It seems like the overall survival, meaning how long patients live, is quite similar with the two approaches, although physicians treating mantle cell patients may debate that or at least think about that a little bit in things. So there's a lot of variability, and honestly I would say mantle cell is something that requires a lot of discussion with the physician and the patient about the pros and cons of different approaches, because there are many different reasonable strategies for most patients. Relapse patients have a number of treatment options. We have chemotherapy that's been around for a long time, and we have newer chemotherapy drugs, a drug called bendamustine, which is sometimes used as initial treatment, sometimes used in the relapse setting. We also have several new drugs or newer drugs that have been approved over the last several years for mantle cell lymphoma. Bortezomib, or Velcade, is one of those drugs that's been approved for relapse patients. That's in the category of drugs called a proteasome inhibitor. Lenalidomide, or Revlimid, is also an approved drug. That is a pill that patients take. It has a number of different effects on the immune system, the blood vessels, and directly against the lymphoma cells. That's also approved for patients with recurrent mantle cell lymphoma. And then ibrutinib is a drug that is also FDA approved for patients with mantle cell lymphoma. That's what's called the Bruton's tyrosine kinase inhibitor, and that flicks switches on the lymphoma cells to essentially affect some of the critical pathways in cell growth. So those are all drugs that are approved for relapse patients. They're being looked at in combination, in maintenance, and as part of initial therapy in certain clinical trials. One of the areas in mantle cell lymphoma is really taking those drugs that are approved in the relapse setting, bringing them earlier in the course of the disease. We recently published a paper looking at lenalidomide, or Revlimid, which is approved for relapse disease, and are now studying that as part of initial therapy so that perhaps patients can avoid or delay chemotherapy for a period of time, and that may offer some advantages for some patients. It needs to be studied further. There are other new drugs that are being looked at. There's a drug called palbociclib. That's a drug that is what's called a cyclin-dependent kinase, or CDK inhibitor. It interferes with the proteins that push the cells through the cell cycle of division. That's a drug that's approved for breast cancer and is now being studied in mantle cell lymphoma and seems to have some activity. There's also a drug called venetoclax. Venetoclax is a drug being studied in a variety of lymphomas. It inhibits a protein called BCL2. BCL2 is a protein that helps keep lymphoma cells alive and make them resistant to chemotherapy. So inhibiting that protein would seem to make sense, and in the early studies with mantle cell lymphoma patients, there have been some promising results seen as well. So all of these are areas where I think there's a great deal of promise, and where we need to continue to have patients participate in clinical trials when it's appropriate to see if they can benefit, if these new options might end up being better than some of the standard treatments, and help us to sort through where we'll fit them and how we'll combine them with the standard treatments. I think clinical trials are very important for all lymphoma patients, but particularly in mantle cell lymphoma. Because there are so many unanswered questions about mantle cell, what's the best therapy? I just alluded to several new drugs that have been approved. Those have all been approved because of clinical trials. And we have lots of new ideas, lots of new drugs that seem to be active in mantle cell lymphoma. They're not yet commercially available, and at least some of them, in my opinion, will be eventually commercially available once the clinical trials are done that establish how they work and what their value is. And so for patients with mantle cell, we're learning more about the standard options, and we have some new options that are important to consider. And I would say that many patients with mantle cell lymphoma, because of the nature of the disease, strongly consider clinical trials at one time or another. R squared is I guess a term, a shorthand for the combination of lenalidomide, also termed Revlimid, and rituximab, or Rituxan. Both of those are approved for different types of lymphoma in different settings. Both of them happen to be approved in mantle cell lymphoma. And so we had done a number of studies suggesting that patients with mantle cell lymphoma, if they were asymptomatic, could be observed. And what we thought was that since you can observe patients, why not consider trying a less intensive treatment, a novel, perhaps in some ways more targeted treatment for the patient, and allowing that patient to delay or to defer chemotherapy. And so the idea being, rather than saving our new drugs for the second, third, fourth treatment, why not try them as part of initial therapy? And our study showed in a small number of patients that the response rates were high, and most of the patients went into a complete remission, and most of those remissions lasted at least 2 to 3 years, and we're still following many of these patients to see. So whether or not that's better than other treatments is not really, at this point, anything anyone can say, but I think it does question whether or not we need to treat every patient with chemotherapy, whether we can use some of these newer agents as part of initial treatment. And I think really it's going to come down to quality of life issues for patients. Is an intensive treatment that's going to give you a longer remission have value despite its toxicity, versus using a lower intensity treatment that has chronic, you have to take it for the long term and may have some chronic nagging side effects, but doesn't have some of the side effects that chemotherapy or other intensive treatments have. So we're trying to get after these issues, and I think the point is that these are complicated decisions for patients to make. Our clinical trials are looking at them, and I think patients really need to sit with their doctor, figure out what their individual situation and their goals are, and then come up with a strategy that works for them. I think it's really important for patients with mantle cell lymphoma to get educated, and I think the LRF has a great number of resources for mantle cell patients. LRF has really been leading the way in many aspects of mantle cell research for a long time now, and has brought a lot of focus into research and education in MCL. Because this is a less common type of lymphoma, doctors who are more generalists, who see breast cancer, lung cancer, colon cancer patients, probably don't see that many mantle cell lymphoma patients routinely. So I think patients need to think about other opinions, but they also need to get educated about the disease, what new things are happening, what the standard therapies are, and make sure the diagnosis is correct. And in some cases, reach out to other patients or to get other support regarding how to navigate the course of mantle cell lymphoma, because it is fairly complicated.